Welcome back to all of you online, and thank you for joining us. We are beginning our next session, which is going to be another insightful discussion on setting the standard, an AI framework for AI-based diagnostics, brought to us by Find. Now, I'm going to introduce the lady who is going to walk us through this discussion, and you get Dia Cabana is the founder and CEO of the Luminous Agency. Her work focuses around research, capacity development, and technology adoption strategies. She's been doing this for over 10 years, has worked strongly in over 40 countries, but she has never had a Kenyan GDHF 2025 round of applause welcoming her to the stage. So let's give her one of those with a massive, massive round of applause. Over to you. Ooh, wait, I need some of your Thank you. Over to you, Yuget.
It is very true. The last time I came to this conference, it was cold. It was in DC. And a lot of what we're discussing here today, we could not imagine it being possible. So I am just so excited that we managed to bring this to the continent. And we're talking about, as our first sister says, we're talking about things that feel like they're also about her, and not just about everybody else. Hello to everyone who's watching us online. So, since the last time I was here, a lot has changed, but also there are a lot of things that are still the same. We're still talking about promises, we're still talking about challenges, and a need for a stronger foundation. And finally, we're talking about data. Back then, it was just talking about the tools and the solutions themselves. So we are here, some of us because we are exhausted by the challenges and we are looking to collaborate and meet others who are going to help us solve these challenges. We're also here because we are advocates for possibilities. We're advocates for ensuring that our health and the health of people we'll never meet and our loved ones is helped. And diagnostics is something that we cannot get around. We need it in order to ensure that we identify the actual problem so we can know what solution to deploy. So one of the things that we've learned a lot over the years from our successes and our failures. And one of the things that we've learned is that we can't do this alone, any of this work. And my collaboration with Find has been extremely encouraging because they've made it a priority to ensure that they've included as many people as possible into developing this structure and framework. We do acknowledge that there are frameworks that exist. We do acknowledge that there are frameworks that are being used and that are helping. And so what Find has done is they didn't start from scratch. They built on everything that's already here. And they built it and structured it so that it's helpful for a really critical aspect that is diagnostics. So today, as we've said, it is a collaborative effort. We are presenting what we've prepared. Our panelists are here to share a little bit about the work, but let's keep the spirit that already started by sharing our experiences when we have the opportunity, because again, we would not have gotten this conference to Africa, we would not have gotten here had we not worked together, had we not listened to each other. So let's continue that spirit. So to keep us, to get us going, I'll invite Aurélien, who will introduce Find's framework and give us a starting point for our conversation. Thank you.
Thank you for the intro. Can we just get the slide also on the screen? So I'm Aurélien, I'm working for Find. I'm leading the AI project there. Find is a non-for-profit organization working on the development and the access to diagnostic for infectious disease and non-communicable disease, and we are working in LMICs. And so we have project on digital health, and AI. That's the topic of today about data framework. But why this matters? I mean, why diagnostic? Why data? Last year, I went to our office in Jakarta, working on similar project on AI-based diagnostic implementation. And I had a discussion with one of our colleagues there, whose daughter has a medical condition. And she had to go, years ago, to health facility to get a diagnosis. So she went there, she gave some personal information, she gave some clinical information, she did some diagnostic, some tests. And she was referred to another health facility. So she took an appointment, she went to the other health facility, she gave personal information, she gave clinical information. Her daughter did the same test once again. She did some new test, and she was referred to another health facility to complement the testing. So she went to the other health facility, she took an appointment, she gave personal information, she gave clinical information. Their daughter redid the same first set of tests, the same second set of tests, and she did some new tests. And she was referred to another health facility, and so on and so on. And it took time for her, and for daughter, to get a diagnosis. It cost her money because she had to travel. She had to pay for the diagnostic several times, the same diagnostic, the same test. And it was also causing some stress for her daughter, for her. And there have been a lot of improvement in Indonesia on it, but at the time, this could have been partially avoided with better integration of the data, better centralization of the data. And so it's why it matters to have data and diagnostic. There are still a lot of challenges in diagnostics, so we talk a lot about data, but I will focus for a minute on diagnostic. There is a huge gap on diagnostic, globally. Only 47% of the global population in the world has no access or just little access to diagnostic. And it's up to 81% at primary healthcare level in low and middle income countries. So there is really little access to diagnostic in many places of the world. The systems are fragmented. Often solutions are developed per project. Like the person yesterday, I don't know if some of you attended the session, but there was someone talking about the huge number of babies in Malawi and all these projects that make a huge family of babies and that are handed over to the MOH, and they cannot keep up and do the handover on all of them. And it's a bit the same with data system. They are developed and then they are fragmented, they are in silos. There are also constraints on human resources, lack of radiologists in country, for example, and the access to diagnostic for marginalized population, people living with HIV, and people having STIs. And for all of that, AI is coming with a lot of promises. AI can improve access to diagnostic. FIND is working on lung ultrasound, AI-based lung ultrasound to detect TB that can go in more remote places. Someone was talking just before, to give access on the last mile to health and so to okay, maybe better like that. To enhance accuracy, there are AI-based diagnostic can support radiologists to, human readers for imaging. It can speed up diagnostic. AI allow real-time analysis for clinical decision. And it can also empower healthcare workers to support them to make that they can take informed decision and no need for supervision. But to do all of this from the AI, there are still some gaps that need to be addressed. Diagnostic data gaps in terms of governance, in terms of trust. One person from Nectar was talking about evaluation, how to evaluate, so having proper data set for proper evaluation of tools before deployment. Issues in terms of bias, lack of equity, in terms of representation. Last year, FIND published a landscape report on AI-based diagnostic for respiratory disease. And out of the 159 solutions that were identified, only 12, so not even 10% of them, were developed by companies having headquarters in LMICs. So it's mostly solutions developed by high-income countries, for high-income countries, with data from high-income countries. And there is clearly a gap and an issue there. Gaps in terms of infrastructure, capacity. So, data storage in the country. There was a lot of discussion the last days about capacity building, training the healthcare worker on the data, for example, and monitoring and accountability. So maybe again, it goes again to the evaluation, and also how to monitor the inference of the AI diagnostic to ensure that there is no, for example, data drift and the performance are as expected. And so we work over the last months on the development of data framework targeting diagnostic use. So we don't want to, like the malaria story, adding a new baby to the data framework family. There are enough baby in the family is big enough. The idea is more to grow this family, not the family, but to grow the child actually, and to provide some new skills, to provide some new perspective. And so FIND is working on orienting what exists, what has been done toward diagnostic. So at the center, the data framework, we of course have the health data coming from electronic medical records, the lab data, imaging, all the health data that we can collect. And around that, we wanted to build data framework that go all over the data life cycle, from data collection to data monitoring to data deletion at the end, supported by governing principle that will ensure that the data are used securely and ethically. I don't know for you, but for me, health data look a bit like that. I've been working on clinical data collection for years. Data come from different sources, they come in different formats, there are different use cases, they have different user rights on how they can be reused, and at the end it's kind of a huge mess sometimes having the clinical data. So there is a clear need for proper integration of the data in a securely and ethically manner. So the data framework that we propose is to go all along it's made of 6 pillars that go all over the data life cycle, from the data collection, so ensuring that data are representative of the targeted population, so we don't let anyone behind, we don't create bias, and we don't actually increase the diagnostic gap. Ensuring inclusivity of the data, in terms also on data format, data sources, to be sure to cover all possible cases. Having proper data validation and data cleaning process for having good data for training, good data for evaluation, but also good data for inference. Having data annotation and data structuring processes is particularly important for diagnostic. Proper annotation of the data, proper reference standard. I worked a lot on TB, and actually defining TB is not that straightforward depending on the population. If you are an adult, if you are on children, if you are on people living with HIV, there are microbiological reference standards, there are composite reference standards, depending on the tests that are available in the healthcare facilities. Reference might be slightly different. So harmonizing all this part, that is really important for having proper diagnostic at the end. Data integration and harmonization, so centralizing all the data and integrating all the possible data. Data sharing and reuse, it's really important for protecting the patient rights, having data sharing agreement, having maybe licensing program, engaging with stakeholders, but always taking into account the patient right at the end. And continuous monitoring and feedback, so monitoring the output, monitoring the inference, and ensuring that the system performs as expected, so have a system to collect the data at the end and to check for data drift, for example. All of this being supported by 3 governing principles on data governance and privacy, so about informed consent of the patient, their data privacy, data protection, infrastructure readiness, having data storage, having computer processes within the country, in order to perform all the data and AI-related activities, having readiness also in terms of capacity building, training on all the data life from the patient providing their data, the healthcare worker collecting the data, but also other people using the data. The developers at MOH using the data at the end, everyone being trained on what is personal data, what are clinical data, and what are the risks related to that. And at the end also storage and versioning, so having data storage following local regulation, having versioning on the data in order to allow reproducibility of the results, which will allow also trust in at the end on the system. And so the framework we propose will promote responsible sharing and reuse of the data, being human-centered approach. We also, I didn't talk about it actually, we are also working with countries. We are collaborating with Rwanda and Indonesia. So we are not doing it only from the FIND office in Geneva, but we are collaborating, for example, in Indonesia on how to adapt this data framework for medical LLM. So really to see what is the health system in the country in Indonesia at the moment. How does it fit with the data framework? What is missing on one side? What is missing on the other side? So really having it country-driven and in collaboration with the country. And yeah, I'm seeing my colleague telling me it's time to go. So now it's time to give the stage again to Huguette for the introduction to the panelists. Thank you.
Thank you, Aurélien. We'll have an opportunity to ask questions, so don't worry. So to introduce our panelists, I'd like to call Dr. Jackie Oguto, please, from World Diabetes Foundation. From there, whichever seat you like. Next, Dr. Shupo Yedepo. Shufa and I was my co-founder for an alliance we started back when Africa was not yet holding these types of meetings. Next, Dr. Shiko Gitao. She's the CEO of a company called Kala, and she's based here. And last but not least, Kirsten Matheson from Transform Health. I took a mic. I'll use this. I was going to sit there. I can't see anything without my glasses. Thank you. This is why I'm glad you're here. Well, okay, so we saw the presentation and Aurélien shared Fine's work so far and the process, and we talked about the importance of collaboration for this work and for the impact we hope it will have. So we have with us here a few people who have done a lot of work in the area of AI, global health, digital health, to help us put a lot of this work into context. So I'll just ask the panelists, starting with, well, Aurélien, I didn't properly introduce you. My apologies. Would you just, 30 seconds, your name and what you do at Fine, please?
Okay. I mean, you already know me now, but I've been working at Fine for almost 10 years, initially in clinical data collection for all the clinical studies that we are running, so more than 50 on TB, malaria, and in all MISs. And since last year, I'm now leading AI-related project and like how we can have AI supporting diagnostic and then improving access to diagnostic through AI, but in a way that respects patient rights.
Kirsten, please.
Yep. Thank you. I'm Kirsten Matheson. I'm the Deputy Director and Policy Lead at Transform Health. We're a coalition of organizations looking at the enabling environment for the digital health transformation, and I lead the policy and influencing work at the coalition, so working across coalition partners with our national coalitions on kind of driving some of this work on the policy agendas.
Thank you. Your mic.
Hi, everyone. My name is Dr. Shiko Gitao. I'm the CEO of Kala. We are Digital Innovation Lab. We are headquartered here in Nairobi and work across Africa. I'm here because I'm Huget's friend. But my colleague Fred, who heads our AI and research work, he's actually Dr. Fred. So I'm here as an imposter in the health space. Thank you.
Hi everyone, my name is Jackie Ogutu. I'm heading the digital health team at the World Diabetes Foundation. And we work with governments, civil society, implementing partners to support governments with an NCD voice and just really exploring the potential digital health has. Yeah.
Morning, everybody. My name is Shupo. That's what everybody calls me, Shupo. I'm a core techie. Technology is all I've done all my life, most of it in digital health. Essentially, I help to develop policy, advice on strategy. I like to think of myself as a technology strategist. That about sums up everything that is me.
Thank you. And so, starting with you, Kristen, the first component of the framework talked about data governance, and I'm very excited to be on this panel with you actually because I remember the starting point for Transform and why it was needed. Will you just talk to us a little bit about what you guys have seen since you started, the progress, the challenges that you're noticing, and touch on how, I know you also have a framework and the role of frameworks in ensuring governance.
Great, thanks. Yeah, so as I said, we're a coalition, it's a global coalition, so bringing together more than 250 organizations. And when we were set up, just realizing that there was a gap in this space around addressing really the enabling environment for the digital health transformation, which is essential to ensure that as we're talking about digital tools and advances, innovations, now AI, to ensure that they are sustainable, scaled, but really importantly, equitable and inclusive and people-centered. We need to really focus on strengthening the enabling environment. So that's where the work of Transform Health came together, but also recognizing that no one organization can do it alone. So how can really we come together? We're a multi-stakeholder platform, so we can really kind of consolidate efforts and kind of bring bring that progress and activation together. But really important of, ensuring that that transformation is rights-based, people-centered, really important to how we work is meaningfully engaging kind of communities, young people, women as part of that digital health transformation. I can maybe talk later about some of the youth work about that. So one of our key focus areas bringing to health data governance is really how we can strengthen national, regional, and global legislative frameworks around health data governance, realizing that, as digital advances, data evolve, AI evolves, generating more and more data, but if it's not used equitably and responsibly, we're not furthering health benefits. So the need to have those stronger legislations in place that have the right protections of health data, but also really importantly ensuring that data is used responsibly, so it is furthering public benefit and health outcomes. But then we also recognize that regional and global collaboration is also really important on this. So we've been doing quite a lot of work. We just had a session this morning, actually with Helena and with Africa CDC, and seeing advances around a continental health data governance framework, but then also how we can kind of elevate that to global agendas as well, for example, through the World Health Assembly, to really have that countries coming together to learn from each other, but also understand kind of what's needed, how we can kind of have these regional and global standards around what is needed, support that compatibility, especially when we're looking at kind of fostering a more secure environment with cross-border data sharing, et cetera. So these are kind of some of the areas we've been working. In terms of how we've seen kind of some of these things advancing, I would say when we set out, we were really advocating for the need for this. Now we're really seeing it happen. So I think this morning's session is really testament to that, Africa CDC making that commitment to lead on the continental framework now, and that's making progress. We've also been developing as Transform Health and working closely with a number of our partners in developing a number of tools and frameworks and resources that can support countries as well as this regional and global alignment. And maybe I'll very quickly mention a couple of those and then I'll finish off. But so we have health data governance principles, and I know we've spoken about that a lot, and FIND also being one of the coalition partners, which provide an equity and rights-based framing to health data governance that can be used by organizations and governments to help guide their data governance approaches. We've recently developed a model law on health data governance, which provides it's a non-binding, it's a framework, it's a blueprint that can be used in parts or in its totality by countries to look at how they can kind of strengthen their national frameworks, and also helps provide a framework for some of this regional and global work as well. And one just final point is realizing, and we had discussions about it earlier today, that we need the frameworks, but they also need to be people-centered, and so you also need to be engaging populations and communities around it as well. So complementing some of this work, we also have a campaign, My Data or Health, which is really aimed at engaging, increasing awareness, and empowering populations, the public, around these issues so they can also demand their data rights.
Thank you so much for that. I'm going to move over to Shiko. Kirsten talked a lot about collaboration, empowering countries, et cetera, in data use. And one of the things that we need is, of course, the tools to make that possible. And I know that a lot of your work is on that, specifically the Africa Health Information Exchange platform. And I know you've worked on several of these platforms for the continent and globally as well. Will you speak a little bit about that and how it's been trying to establish this as we're still sorting out the structure and the governance aspect?
Thank you very much. I mean, I need to acknowledge Dr. Fred, who's doing most of the work. I'm just talking today. So Fred, just wave so that they can see you. I hope I'm representing you well. So at Kala, just to give a background, we are a tech company. That's the base of what we are. And we've been working specifically in the health space. Just before COVID, we became the team that was modeling for the country, the models that were informing decisions around, should we shut down the country, should we do this? And the process of doing that, we realized it was so hard to get data, to just make critical decisions around, should we shut down the country? we had to be calling for mobility data. We were calling Facebook, Google, everybody, please just give us some data so that we can model out our countries. This is critical. And the good thing is it was just a critical time across the globe, and they did give us this data set. But in the process of doing that, we realized that some data sets, even for diabetes and other comorbidities for COVID, were in somebody's hard drive under their desk, and the country is closed down. Yeah? TB has 5 different programs in Kenya funded by 5 different partners, right? And you realize that everybody has their data set, they're not sharing, so making decisions around this is hard. But even harder is getting researchers to start working on this. So part of that is we built this, we call it the Health Data Lake for Kenya, to enable people to just put their data set, and if you want to put it behind a paywall or an access wall, you can put it, but let it be visible, is what data sets are available, where, by who. A nice catalog that is able to accessible to researchers, to policymakers, to anybody. So we're not saying Africa does not have data sets. We've had a lot of that because that data does exist. And we will say, yes, that data exists in PDF, in somebody's black book, but also in somebody's hard drive. Let's first find the hard drive. But how do you solve this at scale? Yeah, so the team came up with this idea, what we call the Africa Health AI and Data Sandbox, yeah? And with support from the AFCTA, it's an Africa-wide engagement, where we are saying, what are the critical things that, as an African researcher, policymaker, need to be able to build for the continent? We need data sets for sure, right? Is how do we start getting this data set? Then we need talent, we need funding, and finally we need the governance structure. So I'm very excited about some of the work that we're doing. And then put it in a place where if I'm in Kenya and I want to work in Rwanda or I want to work in Senegal, I'm able to go to this sandbox and get a regulatory framework that is able to guide me to work in those countries. So we say, okay, regulatory framework is covered, but what are the key other elements that need to be looked at for us to be building? Compute and data sets. Over the past 2.5 years, we've been meeting medics, not medical doctors, medics, so nurses, clinicians, pharmacists, anybody who wears a white coat, basically. We meet them in the office, because anybody in Africa, not just in Kenya, anybody who wears a white coat is a doctor, regardless of whether they went to medical school or not. But how do you empower them using AI? So we started a very simple round table. We meet them, we talk. It's a very open conversation. Is what is AI? How are you using it? What are the challenges? And in the process of doing this, a few things started bubbling up. AI, as it stands right now, and all the tooling around it, will never replace a doctor, even that nurse in your village who is giving you Panadols, or the farm tech who is giving you Panadols in your chemist, will never do that. Why? Because they don't have access to the right tools. So the team built a benchmark. So we said, we have a benchmark for Kenya. Okay, let's put it aside. Then the next thing is, after we're doing this, the doctor started saying, we need data sets, we have data sets. So one team is saying we need data sets, another team is saying we have data sets. So they started donating these data sets to us. So we have a couple of small language models that we've built based on these data sets that have been donated. And then the next thing we said, okay, you have data sets, we are getting talent, what do you need? We need compute. And that is the elephant in the room, is how do we solve for compute for researchers, policymakers who want to do this. Thankfully, earlier this, my brain is already in 2026. In September, we launched the first open AI research lab in Africa. So if you're a researcher, we provide for you with free GPU, with these data sets. So right now we have data sets on AMR. So we have data sets from a few countries in Africa, courtesy of Lacuna Fund, they've given us that. We have some data sets on breast cancer, on the bone disease. I said I'm not a medic, so I don't know what bones are called. They're called osteoarthritis. He said that. So we have these data sets. So we are encouraging researchers to come and build. Because as we are doing the frameworks from a policy point of view, you never know what you don't know. What we are doing as we are building, we are seeing what are the gaps. So for example, the benchmark that the team did, it's called Alama QA. If you just Google Alama means benchmark in Kiswahili, QA, you'll find the papers we are on archive. you find what is that. And it's a methodology that we're putting in the sandbox that anybody can access. So we are building all these frameworks and pieces to enable Africa to build, not just to talk. Thank you very much. I've seen him get...
I was leading in. Usually
you.
we cut each other off in conversation, but we have to be, we can't do that here. And Dr. Fred, thank you. We've spoken before, so it's good to see you, and thank you for contributing as well. Thank you. There's so much I want to say, but it actually builds on well to what I know to be a passion, but also work for Shupo, and who has been doing this for a long time, even though he looks very young. But Shupo, you have been working before we understood that the point of utilizing technology was to access better data, and the point of accessing better data is to ensure that people are getting better care, and so we have a healthier world. Now you've transitioned specifically into looking at the ethical aspects of it. It used to be something we took for granted, and now we've realized that it needs to be a strategic part of our work. So will you talk a little bit about that, what you're doing in this space? And I just want to note before Shivam kills me, be mindful of time, but try to let us know as much as you can, keeping in mind the time. Thank you.
Thank you very much. So the first question I would ask is, how ethical are we about ethics? The most popular buzzwords of the last 2 years has been AI and ethics. I doubt if there's any session at this conference that did not loop AI into it. I will not be amazed if somebody is talking about the place of the AI with the boda who's moving me from here to Karen. My point is, we've started to do, and apologies to anybody who has an MBA, we've started to do what I call MBA speak. Just drop the buzzwords, they look nice, do the flashy slides, do the graphs, blow everybody out of the water. The truth of it is, whether you're calling them frameworks, guidelines, whether it's about AI or digital health, I'm sorry, ladies and gentlemen, it will all fail if fundamentally it's not ethical. So whether you're calling it a framework, whether it's a guideline, whether it's a policy, at the foundation of it is to be ethical. If you think about what Aurelian put out, and think of any ethical framework that you can think of, it aligns perfectly. The foundation is always be contextual. It needs to be about the people who would need to use it. Be fair, be just, make sure it's representative. We all know the terms. But we are suddenly falling into a trap with artificial intelligence in health that about 10, 15, 20 years ago, the entirety of the health sector fell into with digital health. It was just a buzzword. It was a nice thing. You send in a proposal, something, digital health. At some point, sooner or later, we're going to start thinking, do we need a framework of frameworks? No, think about it. Just think about it. Can anybody in this room tell me what a football game would be like if you didn't have a referee? Frameworks are essentially guidelines, rules, and tools. But somebody needs to apply them. So there's a set of rules around football. If a player grabs the ball with his hand, it's a foul. But there's a guy in black, or sometimes in white, without whom that entire game becomes chaos. That's the referee. That's the guy who has the responsibility to see that the rules are obeyed. Recently, FIFA has enabled him and digitally enabled that referee with VAR. Boxing match. There's some guy who calls the boxers together, right, let me have a clean fight, no punching below the belt, no biting, except, of course, you're Evander Holyfield. But you understand my point. So as we think of these frameworks, whether it's focused on health data, or more critically and life-impacting, like diagnostic processes, we need to begin to think of and be bold enough to identify, not necessarily an entity or an individual, but identify the fact that you need governance. Governance is not a phrase. Governance needs to be embodied in an entity. It could be one person, it could be whatever works. But there is governance. Stephen is the president of Helena, which means Stephen is responsible for Helena. If I get unhappy with something Helena is doing, Stephen, one man, is going to be held accountable. Then he's going to go through his team. So we need to put in that accountability. Because without that accountability, what you're going to have is a lot of nice sounding, beautifully printed, colorful guidelines, policies, legislation, or frameworks sitting on your shelf. And then, whether it's Usman in Kano, or is Eric in Ghana, or is Stephen in Kenya, is still not going to get improved care. Because let's be honest, when you go into a lab to take a blood test or get an x-ray, you really don't care about all these things. What you're concerned is, I want to get good care. Earlier, you were talking about the poor girl in Malawi who kept moving, and that girl really doesn't care anything about policy, framework. All she would like is, I've taken one test here, and along the chain, I get service. I get care. So whatever we're doing, if you cannot draw a direct or dotted line to improvement of care, we're just spending a lot of good money. We're just hanging out in Trademark this year, Marriott last year, who knows next year. And we're just doing this huge family reunion once a year. So I'd like to challenge everybody. Leave Nairobi with one thought. How will all of this improve care? If you can't solve that problem, go and watch a football match.
Thank you, Shupo. Well, thank you so much, Shupo. Jackie, somebody I know who is asking herself that question every day is you. I just want you to share with the room what you guys are doing, because I know you connect so many dots. You look at the root causes, which means you're looking beyond the obvious. And so I think that's what I would love for you, is just to share with the room how you approach your work, because there is a lot. We talk about NCDs and the issue it's become for all the continents around the world now. And you're doing a lot in this space, so please talk a little bit about your work.
Yeah, absolutely, and really thank you for including WDF on the panel here. And I just want to appreciate your passion, Shibo. Really, that passionate call for, for us to be better stewards, for the stewardship and pragmatism, and whatever we do, landing it on the realism of what is it that we are trying to achieve with AI. Within the NCD space, particularly diabetes and hypertension, there's significant potential and opportunity. This is a tool that can really shift the trajectory of what we are seeing now is actually a huge global issue. And I think it's about 600 million people now who have diabetes, and 80% of that burden is actually here in LMICs. But the saddest thing is that 40 to 60% of those people who have diabetes don't even know they have it. I was having a conversation just before this session with a lovely lady, and I asked for consent because she shared a story that touched me about her mom, who was fine, doing okay, looked okay, and suddenly had a problem with her eye. By the time she went to the hospital, they figured out something was not right, but she was still not tested or diagnosed. Years later, the issue persisted, but this time she came back with even more complications, beyond just the eye and the retinopathy, cardiovascular. That's when they did the blood sugar test, and it was too late. And unfortunately, she lost her mom. This is something that a lot of deaths that are preventable. So, again, just a reminder why we do what we do and how life-changing it can actually be. At the World Diabetes Foundation, we focus on prevention, we focus on care, we focus on capacity building, especially in primary care, in low resource setting, and we do see the potential of AI. That being said, we also see a lot of gaps. You talked about data gaps, Shiko. We see it, and one of our efforts are two-front with regards to this space particularly. One is really closing those gaps. Some facilities are moving from paper-based. They still have they call it a passport, it's a book. How can AI apply if that data is not harnessed? So we are really working to close these gaps, build the data, harness the data, build EMRs, so that really when you have a strong, solid foundation of that data, then you can, it's not even about sophisticated algorithms. Really, we rise and fall to the quality of the data. We have two use cases where our partners are applying. So one is around screening. And there we've applied a very simple model, find risk model for screening. It is modified and we are validating this with the specific populations, simple question-based algorithms that community health workers can use with simple workflows. This is not AI yet, but again, it's the foundational building blocks. The more data we get, the specificity and sensitivity of these tools can be improved, and this can actually serve better when we apply the learning models on it as well. And then the second one I want to mention that is commonly known is around complication screening with retinopathy. This is actually being applied and successfully in many settings now, and some of our partners as well. That being said, there's also a lot of learning because how they screen is, the images that are taken with the fundus camera, and we have specialists who get to grade these images. And in many of these settings, there's very few specialists. So of course, this could really solve for that challenge of low resources. But depending on how the image is done with different cameras, different setting of lighting, of course, images also you have different color grading based on the population. So there's several things to be considered. And all of this, these kind of frameworks will help ensure that, especially this kind of populations, are considered and the AI is trained in a way that these populations are considered. Otherwise, then, there's a risk of false positives and negatives, and that will undermine trust and undermine the work that we are doing ultimately. So I'll hold for now, but really just a reminder that there's so much potential with what we can do to literally save lives. Yeah.
Thank you so much for sharing. And in there were what we needed to hear. I know we're a bit short on time. I'll hand it to Aurélien, but I just want to say we'll have questions and an opportunity to ask questions later. So please take note of what your questions are. Even once as the speakers leave the stage, we'll still have an opportunity to ask you questions. So take note so that you don't forget. Aurélien, we've heard a lot about just the importance of governance for trust, for accountability. We heard about data gaps, the importance of, with Jackie's story, the importance of ensuring that there is quality work that's being done. So I know that your work has looked a lot into how to ensure that we're using the right approaches, the right tools, the right solutions, etc. And one of the things that I know that you're really deliberate about is the diversity component in every aspect. So would you mind sharing about that?
Yeah, so thank you for the question. And at Find, we are working, so what I was saying is like, most of the tools are developed by high-income countries, and so they are based on data from high-income countries. So one work of Find is to ensure that these tools actually are working for the settings in LMICs. And so we developed a platform that we call the validation platform that allows vendors to install their software. So for the moment is working mainly for CAD chest X-ray, so computer-aided detection on chest X-ray to detect TB. So vendor can install their software on the platform, ensure that everything is working well, and then we switch off the connection. Then they cannot touch it, they cannot access the log, they cannot access anything from their system. And we move to the Find mode. And on the Find mode, we have access to a library of chest X-ray images that we build with partners. We have around 15,000 images, 10,000 from children, 3,000 something from adults coming from community screening, health facility screening, and also from people living with HIV. And we can use this data. They are representative of different LMIC settings. They are coming from different type of machine. We have most of the images in DICOM, but we also have images in JPEG, PNG that really represent the reality at the end. They are not all like perfect images taken in control settings. They are coming from the reality. And we are evaluating this different software on these images to actually provide real evaluation of the performance, and not the performance coming from the high-income countries, but performance coming from data in low and middle-income countries. And we have like proper reporting that will decipher that will split the analysis by subgroup on like countries, on TB history, for example, on people living with HIV, on ages. And we provide guidance to WHO. So WHO published their policy recommendation for cashless X-ray use based on this work. And so this is one way to ensure that AI-based diagnostics are working for the targeted population that they are claiming to work with. So this is one work to ensure somehow diversity in the use of this system.
Thank you so much. We're going to transition into questions, give you an opportunity to engage as speakers. I'm going to change things up a little bit with the fine colleagues. I'm going to invite Mr. Stephen Wanyi to the stage, who is going to lead us through, instead of a Q&A, we want it to be a dialogue, really. So feel free to ask your questions, but it's really an exchange between those who are up here, led by Stephen, who's an amazing listener, and a familiar person to this space for sure. So please come on up and we'll swap places.
Thank you, Higet. I've got tons of notes. I don't know where to start. I'm looking at Shiko, so... Well, I think there's, first of all, I think let's give these guys a round of applause. So this is evidently a very tough topic, and I think Shupo has mentioned it very well. AI is anything that it can be. I think it depends on the person defining it. But I want to give you guys a chance to ask questions. I know we don't have a lot of time, so I'll try and keep it short. Who has a really burning question on something that you want to ask? I think I'll just keep it that way. And please keep your no speeches, I'll cut you short.
No.
Just a question.
I'll go straight to the point. My name is Sharon Nareso. I'm also from the World Diabetes Foundation. Thank you very much for the panel. It's a great conversation going on here. Going straight to the point, AI, we all talk about open source. It's for free. But I would like the panel to talk about the maintenance costs that it takes to maintain AI or to maintain digital health solutions, because that's one of the gaps that we see in our work. So let me just leave it there.
All right. Let's take a few questions, and then I'll decide which panelist answers. That's my prerogative. Sorry.
Well done to other panelists. I think we've heard so much about AI in this conference, and taking a cue from Shupo. What should be like the priority for the continent? And we've seen a lot of experiences from the global now, like talking about the advancement, but we're still struggling with data on the continent. What should we be focusing on with AI? I've heard so many things that I cannot even, I can't connect with them on the basis of where we are as a continent, especially for my country, Nigeria, and so that we're not looking for something and it's all over the place, but we're lost within it. So what should we be focusing on in terms of priority?
All right, one more question from the audience, and then we'll get answers from the panelists, and then equity and inclusion, I need to go to the online audience.
Okay. Yeah, thank you. Thanks to the panelists. I think it's very informative, the discussion around here. My question goes to Aurelien. So I come from Malawi. My name is Patricia Komani, and from where I come from, most of the problems that are to do with poor outcomes when it comes to tertiary level care is to do with the timeliness of diagnosis. So you find someone who comes from a rural area, doesn't have influence, comes to a tertiary level hospital, and they're just going round and round to get help. So my question is, how are we building in improvement in processes to ensure that those people that don't have a say, they should be able to be diagnosed early without, just going around? I have a case of someone who was supposed just to have a VIA examination at the teacher level. Okay, until today, she's just running around because she goes to the hospital, she comes back with no help. So just want to find out how the process itself of getting care is going to be linked with AI and other digital processes so that there's improvement for the most vulnerable people in terms of their outcomes. Thank you.
Thank you. So we'll have the answers. So let's take the first three questions. Yeah. Shiko answers question number 1. Shupo answers question number 2. And Aurelia's question number 3. Let's go. Shiko.
Rapid fire. I was hoping you're going to. Can I answer question number 2, please? Because it's an area that I'm quite passionate about. When people ask, what should the continent focus on? Yeah. So last year we released a paper on AI general, not just in health. There are 5 areas that Africa needs. We need to first of all build an ecosystem. That's the first thing, because we cannot operate where there's no ecosystem. It's even a very nascent one. And the ecosystem is made of 5 things. It's made up of talent, compute, data sets, use cases, and governance. So those things must be in place to do. And when you're talking about prioritization, those are the key things that you're looking at. When it comes to health, when you're applying that same framework to health, is what is the most critical thing that we should be focusing on? And for us, they go hand in hand. It's data sets. We need to digitize and digitize rapidly. Yeah? All those black books, passports, whatever name they come in, needs to be online, because the best way to measure care, lack or thereof, yeah, is by tracking that data. I feel sad about that story, right? Can you imagine if that lady's data was being measured over time? It would have been easy to predict. Maybe what we are not looking at is the underlying factor that might be diabetes or something else, yeah? But if that's not possible if we are not digitizing. So data set is number 1. And number 2 is the talent to know what the data is saying. So I mentioned the project that we are working on, and one of the key things we're trying to do is do data fellows at clinicals, at the sub-ward hospital stage, because the nurses who are putting everything on DHIS, whatever system is there, they are so tired. Asking them to key in another 5 minutes of data, they're just going to make a lot of mistakes. So the quality of data that you actually receive to make any decision is actually quite dirty. So number 2 is just the talent. So if I was to prioritize, if I had the pen to write a policy, I'll be saying digitize and provide the talent around it, because compute, I feel like it's something that is going to be resolved by that. Yeah.
Thank you very much, Dr. Shiko. Dr. Shupo. Can you answer the first question about open source? Especially, you've done a lot of stuff in that area.
So essentially...
And Shupo, no speech. 2 minutes.
Yeah. Speech. Merrick, let me know when I'm too long. Speech. So quickly, my name is Shupo, just Shupo. Open source and stuff. I'm going to borrow from Shiko's statement. Talent is what you need. Talent. If you had the talent to understand one simple concept, total cost of ownership. Total cost of ownership. So the software may be free, XYZ may be free, but there's a cost. You're getting it for free. What is the cost to you to maintain it? And I'm not talking infrastructure, I'm talking talent cost. So you have free information systems, there's free data and all that. Do you have staff? And I'm talking country level public service systems now. If the health systems in the country does not have the capacity to utilize that, then you haven't covered your total cost of ownership. And that, more than anything, is the big problem. The talent to be able to ask the right questions of yourself and of others. And that's why we fall into the trap of, oh, this is free. Sometimes, with all due respect to everybody, Open source is far more expensive than proprietary. I've been told not to give any speech. I rest.
That question?
Okay. Yeah, I was saying like AI can empower healthcare workers. So we can make diagnostic closer to, good diagnostic closer to remote places. There could be like clinical decision support based on AI. We were working last year on integrated disease screening program. So instead of having like different program for TB, for malaria, for typhoid, for fever, for any type that are in silos, having something that is integrated that all at once, and so they don't have to repeat all the time the same question. So first, digitalizing this, and then adding some maybe AI part. There are a lot of initiative at the moment on developing LLM, working more or less. There is also a lot of question about how do you properly evaluate medical LLM. But that could help and support healthcare workers, and then they could properly refer patients. And the work last year we did on integrated disease screening was actually to see the rate of patients that were referred to the hospital, and see if by using that you can decrease this referral, avoiding people to travel for something that might not be useful, and then having healthcare workers provide better diagnostic, a better decision to the patient. So that could be one way to do it.
Thank you very much. How many questions do we have online?
3 now.
You can read them out.
All right. I was just going to use AI to shorten them, and then bang, Aurélien, you finished your answer. So you have caught me with my pants down, but I'm going to read them as asked. So number one, there's been a lot of engagement online. Thank you to all of you who are commenting. Benjamin, Johan, Chams is here and there. Fantastic. Jennifer, Valentine. One question from Carl. He sent 2 questions. Number one, what challenges have you encountered in creating systems that ensure smart data that remains useful and relevant to all stakeholders across the healthcare system? That's one. Second question is, what advice would you give to startups when it comes to selecting the most effective digital health system to support scalability, interoperability, and long-term sustainability? Those are 2 questions. Third question from Johan Botha is, when considering AI diagnostics in primary care, how do we build trust both on the patient and the healthcare provider side? And don't you think that in Africa we need to develop our own Africa AI standards policies instead of relying on international guidelines that are not aligned with our local nuances in diseases, languages, and cultures?
Thank you very much. Panelists, please pick whatever you really, really feel hot about. Shiko, go ahead.
Fred here. So it's a question that question came across from one of our conversations with the doctors is, why do we rely on the standards that are out there? And it goes further that the benchmarks that are out there that are testing these AI tools are not even considerate of African nuances. And I'll give an example that I'm always using from Fred, is malaria is a big disease in Africa. It was HIV, sorry. HIV is a big disease, 40 million people, primarily in Africa. In all the benchmarks, all of them, it was represented by only 6 questions. I can see your eyes popping. And even in those 6 questions, the guidelines they were using was American entrance exams, which meant that a medic anywhere in Africa using any AI tool was being guided by the one question that was used at an entrance examination in Michigan Medical School or something, which loses its local context, how HIV is being treated, what the national guidelines to HIV locally, which are very different from Kenya to South Africa, not even Kenya to Uganda, let alone to South Africa. So having those standards is something, but it's our imperative as Africa to do it. And I remember when we did the first paper, we didn't know OpenAI was going to release their benchmark. We released ours maybe a week before. We released our benchmark a week before the OpenAI benchmark. And then OpenAI released their benchmark. And overnight, we got an email from people in OpenAI asking, can you benchmark our benchmark? Because we liked the methodology that you use. Because what the team did is they used doctors to generate initial questions and then generated further questions using AI, because we had that seed data from actual medical doctors practicing on the ground. We had a standard that we are using. And then we have our own medical guidelines as Africa. Ministries of Health have put so much money to put these things. So those standards, as we are progressing, need to be what we are going by, not what the world is doing, is working on. Just wanted to point out that. Thank you.
Thank you very much. Question number 2. Who feels inspired? Oh, really? Kirsten, let's...
Yeah, I was just going to pick up maybe on the trust comment there, which I think is essential. And I think everything we're talking about is we're talking about digital health, data, AI. Trust is central to that, because people need to feel trust that it's their data, the tools, their information is going to be used responsibly, so they feel comfortable using it, and then it can generate the health outcomes and public benefit we want to see from it. And I think really critical to the trust is it's those legal and regulatory frameworks, because those provide kind of the rules that everyone involved in that ecosystem needs to follow. And it also provides those avenues for redress if people feel that their rights aren't being upheld. So I think that provides those frameworks that are really essential and will help build trust in those systems. I think the other thing is just going back to really ensuring the meaningful engagement of people, communities across all of this, across the development of AI, around governance structures, around data and how that's used, so that they are aware, empowered, and also can hold those accountable around upholding their rights, and then that will also facilitate and ensure better trust in these systems.
Yeah, just to add also on this last question, like having independent evaluation, and so based on local data to be sure that, once again, the systems are working for the country where they are deployed based on the local data in the country.
Thank you. Shupo, I can give you half a minute.
Yeah, so that one that was talking about smart tools, smart digital systems and all that. My advice is this: forget about the digital. Sometimes, I'm a techie, but sometimes the best way to use technology is not to use technology. Forget about the digital, it's about health. Ask yourself 3 questions. Who? What next? Who am I getting information from? Who is going to use the information? What information do I need? When I get the information, what next? If you forget about the digital, focus on the health. There's a design statement that says form follows function. What's the function you need to sort? The form of your digital solution will then emerge. Too many times we start with the digital, then we're looking for a problem to solve.
Thank you. Do you all believe that Shupo is still a technology strategist? I mean, this guy is a politician, right? Give him the mic and you're in trouble. Now, we're running out of time, and I think all of you have been graciously here in Nairobi for the last 3 days. You know that in Africa, we have to follow the agenda until the end, isn't it? So the closing remarks are extremely important, and I'm not going to let you go before I make my closing remarks. Right? So anyhow, I mean, I think we can wrap this up because I think we're all hungry. And I'm not going to say much. Honestly, these guys have said everything that needs to be said. But going back to the reason we came for this session, and really thanks a lot to Find, I think the idea is the data standards for AI-based diagnostics. That's really why we came in the first place. I think it's important for us to go back to why are we here, right? And I think a couple of truths have come out, fundamental truths have come out. It's very clear what the value proposition for diagnostics is. I think Shiko and Jackie have given really good stories about how diagnostics save lives, isn't it? Diagnostics with data and with AI saves even more lives. I think that's what we're heading to, isn't it? So the question is, then why can't we embrace that and save more lives, right? So I think the people, Higet and the rest of the Find team who are working on the data standard framework are trying to solve that gap. We have the solution, we have the problem. I think the panels here have talked about the reason why we are unable to get the best solutions that are AI-powered based on good diagnostic technologies so that we can actually save more lives. So I think the question I want you to think about and throw back to you and reflect on all that is standards comes down to consensus. You know, you're either waiting to develop legislation, which you know takes time, and you don't want to hand over legislation process for AI to politicians. We know why. So as practitioners, I believe most of you are tinkering with AI, right? Isn't it? You're doing some sort of AI, or at least you're interested in AI, that's why you came here. I think as industry, we can influence how we do this by developing standards. And I think for that I applaud FIND. So what I'm inviting you to do is, let's figure a way of working closely with FIND. Let's develop our own standards. I think Shiko spoke about benchmarks. Those are standards, right? Let's think about how to develop standards for AI-based diagnostics that will actually work for us. And out of that as industry, we can then influence the legislators to develop the right laws and regulations. Clap for me, come on.
And I will make it short because I'm the last person between you and the lunch. So on the slide here, you can see like a QR code to access the executive summary of the data framework for government. At the bottom of the page, there is a form also that you can access to provide feedback, to provide comments, to provide criticism. We will look at all your comments. We will try to integrate them in the document. And it's also on this page that early next year, we will publish the final version of the data framework. And on this, I will wish you a nice lunch. Thank you all.
Thank you so much. I'm going to just correct Aurelian. You made a big mistake. I am actually the last person between you and lunch. So number one, a round of applause for our panelists. Thank you so much. I'm going to ask us if we can just stand for a photo as we take the rest of you before you leave. Again, just to thank them, Aurélien, Jackie, Stephen, Kirsten, you get, Dr. Shiko, didn't mention you as well. Shupo, only Shupo, nothing else. Thank you so much for that session. And I know we're all rushing to lunch, but the truth is I know the nourishment was here, so there's no rush. We can extend the session for another 45 minutes, I am sure, and continue on. We are going to break for lunch. Thank you, FIND, for giving us this session today, this last one. After lunch, we shall resume at 2, and I believe there will be some virtual programming happening, but again, just follow the agenda. You'll be able to see everything you need from there. And looking forward to concluding, well, I'm not looking forward to concluding the 3 days, but we'll be concluding the 3 days in the afternoon. Thank you so much for your time. Another round of applause. Thank you.